Could psilocybin help people with eating disorders process unconscious trauma? What's the difference between the effects of psilocybin and SSRIs on depression? How does formulation and route of administration affect an LSD experience? What role does self-compassion play in the treatment of PTSD with MDMA-assisted therapy? In today's episode of the Psychedelic Therapy Frontiers podcast, we explore recent research on these topics and much more. For those of you who are new to the show, welcome. Psychedelic Therapy Frontiers is brought to you by Numinous Network and is hosted by me, Dr. Steve Thayer, and my co-host, Dr. Reid Robison. Just a few quick announcements before we get into the episode. If you're looking for comprehensive foundational training in psychedelic-assisted therapy that includes live online classes, experiential learning, and opportunities to connect with a diverse community of practitioners in the psychedelic medicine space, then check out our courses. We're offering 10% off select courses for PTF podcast listeners, so click on the link in the show notes or go directly to numinousnetwork.com/training, where you can use the code PTF10 for that 10% discount. If you've listened to our show for a while, you've likely heard Reid and myself talk about the psychedelic clinical trial work that Numinous Network does in Utah. So if you live in Utah and are interested in being a participant in a psychedelic clinical trial, you can click on the link in the show notes or go directly to numinousnetwork.com/research to learn more about the trials we're currently running. If you'd like to support our show, here's how you do it. Leave us a rating or review in places like Apple Podcasts or Spotify. If you're watching on YouTube, you can like the video, subscribe to the channel, and share the episode with someone you think might enjoy it. Without further delay, here is today's episode.
Hello, Steve.
Good afternoon, Dr. Reid.
How are you?
You beat me to it. I'm doing well. How are you?
How are you?
We're fine.
Fine. Get on with the show.
Yes. So today for the show...
We're grumpy today or something.
You know what?
Should we just call that out?
Just change the mood instantly. We're talking about some interesting studies today.
That'll brighten everything.
Brighten everyone's day. Yep. Stuff that we find interesting, and hopefully, if you're listening to this show, you find interesting too.
No, they're universally interesting.
I think so.
No.
So
cool.
I'll how about I toss the first one out, get you to react to this one. So this was a case study that came out of I believe Compass Pathways data. On a small sample size, open label pilot study for psilocybin for anorexia nervosa. So
yeah.
One of the things they discovered and what led to this case study was that for a couple of the participants, there was some sort of unacknowledged trauma that came up during their psilocybin experience, that the processing of which in the follow-up sessions ended up being, they think, pretty crucial to the positive outcomes of these two individuals. So it has some interesting implications for maybe the role that trauma plays in folks with anorexia and what psychedelics, psilocybin in this case, could offer.
Yeah.
So I just wanted to read real quick. They have these short descriptions of these two case reports. So this was published recently in 2025 in the Journal of Eating Disorders.
A follow-up to their initial publication, right? That was like in 2024, I think, of the pilot study. Preliminary efficacy, safety, feasibility.
Right. So first one, this person, anorexia nervosa, history of bulimia, reported severe childhood weight-related bullying and suspected but could not recall sexual trauma. So she reports during the dosing session, she vividly relived a college incident of sexual assault and initially experiencing panic, yet grounded with therapist support. So I think this is an interesting aspect of that. Like when trauma comes up under altered states of consciousness, it's not necessarily pleasant, right? You can be confronted unprepared with some really, really disturbing either memories or...
Both the client and those holding space.
Right.
Confronted unprepared.
Right.
Hopefully not unprepared on all fronts, right? You prepare as much as you can for stuff to emerge, ideally.
Right. Yeah. You prepare with sort of, grounding resources. You prepare with willingness to be open and go in and through, and you've got the compassionate, attentive support of the facilitators.
And informed consent around the fact that things may come up.
Right.
Like unexpected, difficult.
Yeah, and like we've discussed in the show before, it's difficult. The informed consent conversation is a whole other conversation with psychedelics, but it can be really difficult to truly inform somebody about something that is ineffable and hard to predict, right?
Ineffable informed consent form.
Exactly. So she goes and report over the following week, this person's state trait anxiety scores spiked, but then subsided. And she described feeling distressed, but thankful or grateful.
Yeah. And that's an interesting thing to highlight because, we talk about the only way out is through. Sometimes you feel worse before you feel better.
Right.
And that kind of perspective of it being worth it can make a huge difference. Sometimes all the difference in like being able to forge ahead through the work.
Well, and what's interesting about this is that by 3 months later, after the dosing session, her EDEQ global score had fallen quite a bit from 2.7 to 1.7.
And that one's like gold standard measure of eating disorder. It's the eating disorder examination, kind of overall eating disorder severity. And so you said it fell.
Yeah. Which is a good sign in the case of this. It means symptoms improving, and her BMI had gone up. So
also a desirable thing in anorexia.
Right.
Yeah.
So there's, in the discussion section of this paper, again, these are just small sample case reports, but
2 of the 10 had reemergence of dissociated trauma, essentially.
Right. Yeah. So that might be the case that for some folks with eating disorder pathology, that there might be some trauma that is relevant to why it formed and how it might be treated. So, this person said of their psilocybin experience that psilocybin gave me the opportunity not only to find out what I was blocking out, but to make peace with it.
Yeah, I love that. It's a good quote they chose to, it's quite telling. And I've seen this many times happen, situations like this with not just psilocybin, but other medicines and in eating disorders and other conditions too. Like a couple come to mind. I remember maybe 6-7 years ago doing a ketamine pilot study at Center for Change, Eating Disorder Treatment Center, down the road from us, where I just was this morning. And this was, we published it, group ketamine therapy and individual therapy, dietary therapy, all going on at the same time. And during one session, I did groups of 4, and there would be me and 1 or 2 other people kind of holding space, administering the medicine. And during one of the sessions, an individual with anorexia and OCD had this kind of during a ketamine session, emergence of this past trauma that she hadn't spoken about. That was a really, well, there were a couple things that came up. One was kind of a scary kind of natural disaster kind of incident. Another one was a sexual assault trauma. And she was like re-experiencing it and speaking of it as if like she were talking to the individual, and it became very clear what was happening. And just speaking of the therapist container and everything, there was me and a nurse and a nurse practitioner. They were both female, and as I approached, knowing the nature of this, kind of in the moment, made sure there was female presence there to hold her hand. And as we did what we could for grounding and calming from there, and it turned out to be a really productive session or thing to come up, even though it was, difficult and unexpected and all that, like you're talking about. Yeah.
And we know this about trauma, that it can be very difficult to face these things, but facing them with support, with context, can be really integral to the healing process. And the other case example, similar story, that they talked about how they felt like psilocybin helped give them access to the entire memory, where they didn't feel like they had access to the entire memory, and they were able to process it in that state. That's the altered state that psilocybin proffered.
Yeah, interesting. It certainly speaks to the potential value of this kind of tool, right? It goes without saying, but I'm just continually in awe at the potential and also the challenges.
Yes, indeed. So that's that study. Maybe I'll ping pong it back to you. What do you got for us, Reid?
Did you say before we started recording that you also had something on emotional blunting, and because we may want to go into that, it seems related. I'm just thinking about the kind of emotional richness that can come up on something like psilocybin in contrast to what's been described in the literature of an emotional blunting that can happen and often does for many people taking a more traditional antidepressant like an SSRI. And so I'm curious what you've found and what we might chat about on that front.
Yeah, so this is an article recently published in the American Journal of Psychiatry. Carhart Harris, I think, is the lead author. You got people like David Nutt on there. And so these are brain scans, but also subjective reports about the difference between reduced brain responsiveness to emotional stimuli with escitalopram, but not psilocybin therapy for depression.
Okay, yeah, I've seen this study.
Yeah. So it's a secondary analysis of this randomized controlled trial, N of 59 participants. So they compare psilocybin-assisted therapy with the SSRI, escitalopram, on responsiveness to emotional stimuli. So the long and the short is they found that people had similar outcomes in their depression between both groups, but the folks on the SSRI had sort of a blunted emotional response to these different stimuli that they would give them, like faces expressing certain emotions, and they were doing brain scans to see what lights up. And
they're looking at overall emotional reactivity and like both like negative and positive ones, perhaps.
Right.
Yeah.
And then the brain scan, they're looking at, it's called BOLD, blood oxygen level dependent functional MRI, so fMRI in these two groups. And so they found that like I said, the folks on the SSRI have sort of this emotional blunting, but the folks that were in the psilocybin group did not. And so there's a guess here that I'll read this little punchline here. These results are consistent with prior findings that the antidepressant action of SSRIs is often accompanied by a reduction in emotional responsiveness, but this effect may not occur in psychedelic therapy. In this case, with psilocybin,
which appears to expand that emotional responsiveness, or expand perhaps like the breadth and depth of the emotions you can experience, both the positive and the negative, which is really interesting to think about these two paths to recovering from depression, of the traditional one with an SSRI, and what is, I think, great about that report is that both led to a positive outcome for a statistically significant portion of people in their depression. But the SSRIs have this mechanism of, like, it's interestingly from a serotonin pathway, 5-HT1A instead of like 5-HT2A. But that pathway is like putting your emotional system in a cast for a time so it can perhaps heal, recover, or not get to overwhelming, counterproductive places outside the window of tolerance. Whereas psilocybin in the right container, without getting into like too difficult, can like bring back on board that range of emotional kind of experience, and which, like, that emotional richness and well-being that comes from that, I think is certainly for me, and many would argue the preferable path if we can do that well.
Right. Yeah, I mean, and you mentioned in there that without it getting into too difficult territory, one of the other interesting things they notice is that SSRI also sort of downregulates activity in the amygdala, whereas psilocybin did not. So not only are you more sensitive to emotional stimuli that might be desirable, you're also more sensitive to those emotions that might be less desirable.
Yeah, this is
in the moment.
Yeah, it's fascinating. And this is a bit of a tangent, but it reminds me a little bit of the first kind of hospital or clinic-based psilocybin study that I know of, or one of the very early ones from the 1950s in France. And I think what was happening at the time was Albert Hofmann, who essentially invented synthesized LSD and did the famous bicycle trip. He was such a brilliant chemist that when there was this this interest in psilocybin in America and Europe, and Europe had been studying mescaline and other things. Someone gave psilocybin to Hoffman to reverse engineer, and he like helped identify or synthesize, kind of recreate psilocybin from like psilocybe mushrooms. And back then you could freely, like Sandoz was doing with LSD, freely pass it around to therapists, psychiatrists to use in different ways. And in fact, LSD was sent around saying, use it in therapy or use it as a model of psychosis. But there was this, some psilocybin ended up at a hospital in France, and researchers, a psych hospital, and researchers were studying it. And there's this case report from that's been kind of republished in recent years, but from like the mid 1950s, where an individual with anorexia got, I think it was like 15 milligrams of IV psilocybin. And I just find it fascinating what they did with set and setting back then, because they didn't know, they didn't have an appreciation. This was all new. Like it's easy to be appalled at, but you'd get this dose of this, whatever this medicine is they were trying out, and you'd get kind of passed around from, you're going into the psychometrician's office, the psychologist, he's going to interrogate you with with these cognitive, like IQ tests and paradigms of all sorts of things. And then you go and get poked and prodded. And it was quite dysphoric. And like the researchers, observers thought, okay, this doesn't seem to be that helpful of a medicine. They put this gal with anorexia who was severely underweight, very low BMI, like medically compromised because of it, and wasn't making much progress so far in the hospitalization. They put her back in her room, and in that setting, that's when the choir of angels appeared, and she had a mystical experience. And then so the next day she's like, oh yeah, how was that for you? It looked boring. And she's like, actually, and they're like, what? And so they reduce her Thorazine, that was an old school antipsychotic, potentially interfering a bit. And they then give her another dose, maybe a bigger one. I'm a little unclear on the details because it's been a minute, but, she proceeded to have, over the next couple of weeks, some significant progress in her weight restoration and things like that. And not a perfect, easy, linear path to a swift recovery, like highlighting the need for ongoing work. But yeah, it's really fascinating to look at it as a tool, and also kind of sad how long it's taken to keep exploring this. I'm on I mentioned to you before, a safety committee for one of the anorexia studies at UCSF. I just jumbled that. And looking at psilocybin with some family involvement, for example, and then Imperial College has one going on, and we're always trying to get funding to do some pilot work on that front here too. So.
Yeah. I mean, I agree with you. It's and we talk about it a lot. It's tragic that the research stopped, but man, we keep doing these research episodes because there's just a lot of research coming out right now. It's exciting stuff. And you'll get like a really good clinical trial with a lot of great data, and then you'll get 4 or 5 articles out of it, and keep reanalyzing the data. So yeah, this one's encouraging, this sort of comparison to, and Carhart Harris is pretty good about doing that, then comparing psilocybin to antidepressants. Yeah,
so there was a study, I think even more recently than that one, at least a study that mentioned, interestingly, a rate of emotional blunting on SSRIs, and pinned it around 50% or more of those that experienced a diminished range and intensity of emotions on SSRIs.
Yeah, and that's, and clients, patients will often, that's one of the things that they don't love about their SSRI, is that they feel like a zombie. They feel emotionless. Sometimes if the emotions are so chaotic, you trade that for the symptoms that it's treating. But
yeah, that's the way I see it, is that SSRIs can be, and have been in my kind of experience and observation with a lot of people, life-saving for when used in the right way for a time. And when you don't have other options to get through that, right? And they could be part of the plan with all sorts of other wraparound support and therapy, ideally.
Which is also what makes me excited about the addition of these psychedelic medicines with therapy to the toolbox, is that it's not necessarily, it's not like we're going to like, oh, we're getting rid of SSRIs, but here's maybe a different route to similar, maybe even hopefully better outcomes that preserves your emotional tapestry, your emotional color palette that you have access to.
Yeah. Well, cool. Do you want to give one more study while we're on a roll and just see what else you got?
Yeah, this is another reanalysis of data that was recently published in 2025. So this comes from the MAPS data on MDMA-assisted therapy for PTSD. And so they were trying to look at potential mediating variables. So you've got, somebody with PTSD, we give them therapy and MDMA, and then you have outcomes. But what's happening in between those two things, right? Is there something that changes pretty reliably in a person undergoing this treatment that could account for their reduction in PTSD symptoms, and in this case, also depressive symptoms? And a couple of things have floated to the surface as potential mediating variables. Like in the psilocybin literature, it's emotional breakthrough, or it's psychological flexibility, or it's, increased rapport between the client and the therapist. There's a lot of interesting things. In this one, they found that it was self-compassion. So they gave
at what point in the...
I'm not sure at which point, just, somewhere between study start and they, in the MAPS trial, they had 3 different medicine sessions with a whole lot of therapy.
Yeah.
And in study end, they had improvements in both the increase of self-compassion and the reduction in uncompassionate self-responding. So people who were sort of self-critical. And by statistical analysis, they demonstrated that for the most part, people who had these elevations in self-compassion and reduction in uncompassionate self-responding were the ones who experienced benefit.
Cool. That's in many kind of psychedelic studies and pilot programs that we've done, I've included a self-compassion scale in there as one of the measures, including like some of the early ketamine therapy for anorexia work we did at Cedar Clinics, for example. So it's really neat to hear it coming out as a predictor in trauma work with psychedelics.
It makes a lot of sense, right? I mean, for so many of our mental health conditions, like a large factor, for lack of a better word, is shame and self-loathing. I mean, kind of makes sense with something like depression, but sometimes people don't realize that with PTSD, depending on what's going on in a person's belief structure and the way they feel about themselves, self-loathing, survivor guilt, all kinds of things, that if you can improve that, and we know from the effects of MDMA, it's a pretty reliable effect, subjective effect, that people feel love. Sometimes it's referred to as a heart opener. And that it puts into perspective the things that they've been feeling bad about and helps them give themselves the benefit of the doubt. So it doesn't surprise me, but it's cool that we've actually see it in the data. And
I think it brings up all these other questions too of, okay, what are the differences? What are the other differences in this group, and what other traits or things are present at baseline related to this? And also, I think even more importantly, how do we work to increase self-compassion through the course of therapy, medicine or not,
Yeah. I mean, this kind of research informs how we might do this in practice. So if we know that the increase in self-compassion is as a mediating variable, then maybe we focus on that in preparation. Maybe if it shows up, we focus on it in the integration sessions, if we know it's such a powerful thing.
Yeah. What do you spend time on in the limited time we have with clients, and including in a non-directive way, and just like, how do you support and cultivate the most important things?
Right.
I have a study, maybe there's a quick one that may be kind of relevant, but another example of a study that is kind of maybe validating what we intuitively think about the field. But there was a study about coping strategies during challenging psychedelic experiences that was a qualitative survey study of people who had extended difficulties after using psychedelic drugs, and what coping and support strategies were used, and what ones seem to be helpful in this like retrospective look at it, that we can take an inventory on, and even if not earth-shattering in its conclusions, I think it's really important to, like as researchers, to have these kind of things cataloged and verified and shareable in the body of literature on this field, especially around something we talk about a lot, like challenging experiences. How often do they occur? What is this like, and what do we do?
Yeah.
But anything.
What'd they come up with? What did they report?
So they identified these kind of three main coping strategies, core coping strategies: self-education, like learning, journaling, critical reflection to interpret the experience. So it kind of highlights the need to really carve out the time for that. Like
an inquiry, like a self-inquiry?
Yeah, and like in some of our psychedelic studies, there's part of the protocol of time built in for the participant to just journal. And I found that kind of helpful, because if it's not specified, there is a risk of, participant or maybe even facilitators just being very chatty and talkative. But that time going inward and thinking about, reflecting on, writing, processing, I think is highlighted here, and extremely important. That is a good reminder to me of like just making space for that.
Yeah, it's a sense-making process too, especially if it's a very challenging experience and leaves you confused. Taking time to till the soil, or pick your metaphor, but taking time to reflect makes sense. Why it would be very supportive. And
then the next one was social support in the form of seeking help from friends, loved ones, or peer groups. And another one that goes without saying, but isn't always in place. And, as we understand more about how often these things occur, and as we work with doses and medicines where they're more likely to occur, the especially challenging ones, I think it's important to put an emphasis on that too.
Don't worry alone.
But
I've known people, and I even had clients talk about that if they've had a psychedelic experience, they don't have anybody in their life that they feel like they can talk to about this very weird experience, especially if they've had the psychedelic experience in a non-legal context, then they might feel a little nervous about talking to other people about it.
Judgment, and like, it goes without saying as well, but we're not always the most open with our close relatives, family members, right? And there can be some big walls there. Like I'm struck by it routinely. Like even I was sitting down with a client this morning, just kind of doing an intake assessment, and through the social history, I think we might assume that there's more of an existing relationship in place with parents, but like in this case, the individual was just now creating a relationship for the first time with her father, for example. And the family dynamics are so varied for all of us. So seeking, and we also, in our psychedelic therapist and facilitator trainings, we always talk about, how you can counsel the individual to pick wisely who they're going to share with. And there are some challenges that come from like sharing too much with the wrong or non-supportive individuals.
In fact, I was just talking to the students of the Numinous' Fundamentals of Psychedelic-Assisted Therapy course that we teach about this morning.
Cool.
Well, we talked about it in terms of the setting, because today we were talking about preparation sessions and setting intentions and the importance of mindset and setting. And that you can think of a person's social environment as kind of a macro setting versus the micro setting of the actual room that you're doing the psychedelic therapy in. It's the context that they're coming into the session with, the availability of support, the quality of that support. Are the people that are close to them a source of distress or not? These are things you want to sort of get a sense for as you're trying to build resources for somebody who's going into a psychedelic session. Yeah,
I remember after a dosing session in one of our studies quite a while ago, there's always a support person as a ride home and a support person. But the support person, quote unquote, may not always be that supportive unless you've put some awareness around that and some like open discussion and emphasis on it. And because I think someone on the ride home got into a triggering partner like
argument
spat.
or something. Yeah.
And so that made me kind of just extra aware of the challenges, and maybe spend some extra time on the discussions from then on, and the warm handoff and the involving as early as possible in the preparation process when able.
Right. Yeah. Any other strategies float to the surface?
The other
there?
category was mind-body practices, including meditation, grounding, exercises, rest, and sleep. So you might have been able to guess, but like I'll always take a reminder on those, and it's nice to see them shine to the top of like all the possible strategies, just with some weight to support it.
I'm glad, even as you said a couple times, they might go without saying. I'm glad there's a survey study that says it.
Yeah.
Like you said, the reminders are important. It's sort of the first principles fundamentals, and we need to return to and practice the fundamentals. So unsurprising maybe that these things that those categories emerged. But the fact that it's unsurprising is maybe a good sign. Like,
yeah, it's consistent with perhaps the hypothesis and where we have a hunch things are headed. And so we don't have to do a complete U-turn and reinvent and go back to the drawing board.
Right.
But if anyone listening wants to read more in the paper, it highlights kind of which methods are perceived as adaptive or maladaptive, and kind of offers some thoughts on designing integration programs. But it's by Robison et al., Frontiers in Psychology, 2024, Coping Strategies.
Coping strategies. Love it.
Yes.
Well, I've got one more. This is a pretty nerdy one.
Bring it on.
Title of the paper is Absolute Oral Bioavailability and Bioequivalence of LSD base and tartrate in a Double-Blind, Placebo-Controlled Crossover Study. How's that for a title?
Ooh, I was just thinking about this. I mean, because we're doing studies with MindMed, LSD for anxiety, and now the indications are expanding as well. But initially in phase 2, it wasn't an oral disintegrating tablet, but now in phase 3 it is. And so that's brought up like in all the kind of investigator brochure and protocol, some education around that, some interesting stuff, because we use ODT formulations in psychiatry for buccal mucosal rapid absorption. But yeah, it was cool to see that being used for LSD. And yeah, anyway, what did the study show? What jumped out at you?
Yeah, I mean, one of the reasons that, even though I'm not a pharmacologist and I'm not a chemist, it's just the routes of administration and the doses of psychedelics for therapeutic use are I'm really curious about, because I think they have direct implications for how this is going to look in the clinic setting once it gets out of the lab. So in this study, they did a double-blind, placebo-controlled comparison of LSD with, I think, 4 different formulations.
Probably in Switzerland, where they get to do this.
Right.
They have figured out a good system for getting these IRB approved and things.
Right. So they did it LSD base and tartrate, sort of bioequivalence. So they had to do some math here, but an ethanolic solution, so kind of like a solution, alcohol-based solution. I think that's what that means. And then a watery solution. I think the ethanolic solution was a little thicker.
The phase 2 work we did was a tartrate.
Yeah.
Yeah.
And then the ODT, the dissolvable tablet, and then IV. And so they found that basically, regardless of route or regardless of the different types of solutions here, base or tartrate, that, and the dose was about 80 milligrams, by the way, that they were all essentially bioequivalent.
They give 80 IV.
I think so.
Yeah, cool.
Yeah.
Bioequivalent, well, essentially.
Absorption.
Okay.
Yeah, like 80%. So absolute bioequivalability of oral LSD was 80%. And similar for all tested formulations. So interesting how bioavailable it was, 80% absorption.
Yeah, and then so if you give it IV, it comes on quicker and
Right.
and
More
has
intense
that peak that surges and matters for the experience, right? Like I think in that study there was more nausea, there was more of a challenging experience when given IV.
Mm-hmm. Yeah, anxiety on the come up, and nausea, and it's kind of more. They call it the bad, quote unquote, bad drug effect,
Yeah,
compared with LSD oral base and tartrate.
and the ODT is nice because it's essentially ODT. Originally meant these thin strips or strips of film where something could dissolve on the tongue and get absorbed, mostly in the buccal mucosa and maybe a little sublingual and some oral, whatever you swallow.
Yeah.
And there's this technology made called Zydis that is an ODT, like a brand of ODT that's probably the most well known in healthcare anyway, because some big drugs have adopted it, like Zyprexa Zydis. Sometimes even people call it Zydis when they're giving Zyprexa Zydis, but it's this quicker dissolving way of giving it. That's convenient. You don't have to, swallow, but it has this more predictable kind of dispersion on the tongue and absorption. And then, yeah, so I think it's, I was excited to see when MindMed landed on that for the phase 3 stage of this drug development.
Yeah. So we'll see. I like that this basic science is being done, and like I said, it's going to inform practice, and excited to see where it lands once LSD actually gets prescribable. What form is it going to be prescribed as? Maybe this ODT.
Yeah. All right. Well, anything else on that study?
Nothing that I would feel competent to to interpret, given the complex chemistry here.
Like you said at the beginning, though, it's not only dose that matters, but route of administration. Like this becomes really evident and a topic of interesting discussion and debate in the ketamine world.
Yeah.
But like looking back at our experience with the Cedar Psychiatry clinics and Numinous clinics of rolling out both ketamine therapy, Spravato work, different ketamine-assisted therapy protocols, you have these different options for giving ketamine. Like you could be giving an IV drip. That means a lot of things depending on your drip rate and how, but you have the ability to keep it constant or turn it up and down during, but you're also tethered to an IV. And you have this IM route that's kind of still a pretty rapid onset compared to sublingual or intranasal, but you have this kind of predictable arc of a trajectory, and then nasal spray, sublingual, which are I think more commonly turned to for like guided psycholytic or ketamine therapy sessions. Not always, but ketamine means very different things in terms of what the non-ordinary state is like at a certain dose of a nasal spray, or even at the same dose of a nasal spray versus an injection or IV.
Right. Yeah, like you're saying, route of administration matters. You can have, essentially the same bioequivalence in the bloodstream depending on route, but if the route is all at once in your bloodstream really quick, then you're going to have a different type of experience. And that's what they found here. I found this little piece here. IV LSD led to quicker onset and higher peak ratings basically across the board on so-called any drug effect, good drug effect, ego dissolution, and anxiety. So they felt like it was more intense experiences, particularly in the dimensions like oceanic boundlessness and anxious ego dissolution. So again, it informs therapy. Are we going to give this quick and all at once, or are we going to give it slow?
Yeah. And I should clarify with ketamine, those routes like IV, IM versus say sublingual or even oral ketamine, very different bioavailabilities. Like because it's an example of a drug that doesn't have as close of bioavailability across the formulations as LSD does, for example. It could be like 40 or 50% of bioavailable by going to oral or intranasal for example. That's why when Spravato was being developed, I think I mentioned this even last time a little bit, the early ketamine work that I did on clinical trials with Janssen, 14 years ago or so, was they were looking at the IV formulation and then making this one enantiomer of ketamine, not only in a nasal spray, but in a dose for that part of the ketamine enantiomer mix that would get the right amount of receptors occupied by the drug and the right effect on depression in this case.
Yeah. So that's all I got. Any other studies you want to talk about?
Well, do we have time for any more studies?
Why don't you give us one?
How to choose a study. So we could venture outside of the psychedelic realm and just talk about one random thing that I encountered. It's a study of home-based TDCS for major depressive disorder. You familiar with transcranial direct current stimulation?
Oh, yeah, not very much, just enough to have heard about it. But
I think we have a device, or had one in the Springville clinic, for example, because you can buy them. There are home versions, clinic versions, both. It's been studied mostly in clinic settings, but this was looking at home use of it. The study's called Home-Based Transcranial Direct Current Stimulation Treatment for Major Depressive Disorder, a fully remote phase 2 randomized sham-controlled trial. And sham in this case was probably, the device looks like an old Sony Walkman or something, and also has wires coming to it, but instead of putting them in your ears, you put one on above your forehead and one on the temple, for example, because of what we know about depression is associated with decreased activity in the dorsolateral prefrontal cortex. So you're covering those areas and passing a current through it, similar to how TMS, this big magnet, is shining like an MRI strength magnet at that part of the brain and causing the neurons to fire. This is doing something in maybe a less dramatic way.
So the sham just means it's the same device, but it's not delivering the current.
Yeah. So in TMS studies, sham would be it looks like the same helmet that's making a buzz, but it's not giving you any zaps. And compare that to MDMA studies are usually, there used to be a very tiny dose of MDMA. Now it's usually placebo, a real placebo, not an active placebo. In ketamine studies, it's often been a certain benzo like midazolam. Psilocybin studies might be placebo. They might have a low dose group or two, or some of them we've done have even used niacin as an active comparator because it'll bring some tingling and flushing for some in the skin. And psilocybin might have some weird body tingling or whatever. There's not perfect options sometimes, but it's interesting. And anyway, this was a remote multi-site study across, also interesting, the UK and Texas. Go
interesting
Texas.
Populations.
178 adults with moderate to severe depression, randomized to get this device that works or doesn't, and you use it per protocol, meaning 5 times a week for 3 weeks, then 3 times a week for 7 weeks, 30 minutes at a time. You could be reading a magazine during. I say that, but who reads a magazine these days?
It's been a while.
You could be doom scrolling during. I do have a study on doom scrolling. I won't include it this time, but and then they looked at the HAM-D instead of the MADRS, because this is fully remote and MADRS is clinician administered. I don't know for sure, but I think it was the self-report version of the Hamilton and the active group. So the active group had a reduction in their depression scores on that by 9.4 points, which is good. You look at the the sham group, and there was a mean 7.1 point improvement, and that was a p-value of 0.012. And it shows you that So that may not be that, it might not sound that impressive at first. Like it is statistically significant, like very, 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 very unlikely to occur just from chance. But if you look at other things like the remission rate at 10 weeks, what percent of people actually got down to normal levels of mood score that wouldn't be considered depressed even mildly? And that was 45% on the active, 22 on the sham.
Yeah.
It starts to look a little better. But what's interesting is that this is just showing a home-based option, interventional option. That's not a non-daily pill that was feasible, safe. There might be some discomfort, headache, some reactions to the stickiness of or whatever. But it suggests some promise for maybe scalable, accessible treatment options in an interesting way that is based on this rationale of what we know of brain networks.
Yeah, super interesting that stuff like, I know you've talked a couple times about TMS, but these sort of direct brain stimulation tools that don't involve ingesting a chemical, how effective they seem to be. It's cool. I'm all for, like I keep saying, I'm all for many different tools in the toolbox here to help people.
Yeah, and those devices, if you think about the barriers to getting access to TMS, and TMS doesn't work for everyone, of course, or everyone would get it who needs it, but they still wouldn't, because it's expensive, and you have to go into a clinic every day, or like 5 days a week or so for several weeks for this 30 minute visit. And not everyone can do that. Like either afford that or break away from life's duties weighing on you. These things may still cost $500 or so, but technology that may come down, and still, like, the course of TMS would probably be $5,000 out of pocket.
Right.
So it was nice to see it start to approximate the clinic-based studies too. So anyway, I thought it was interesting. Yeah. Interesting studies,
right?
What do you know?
Well, here's to clinical research and the scientific method. Hopefully something we talked about today was interesting enough. Until next time.
Thanks, everyone.
Psychedelic Therapy Frontiers is brought to you by Numinous Network, a company committed to helping people heal and be well by delivering technology-driven clinic support, clinical trial research, and comprehensive practitioner training in psychedelic-assisted therapy. You can learn more about Numinous Network at numinous.com. That's numinus.com. If you enjoyed the show today and you want to support us, here's how you do it. You can leave a rating or review on places like Apple Podcasts and Spotify, subscribe to the Numinous YouTube channel, like the YouTube videos, and share the show with somebody you think might enjoy it. If you're interested in comprehensive training in psychedelic-assisted therapy, check out our courses at numinous.com/training. These courses are carefully crafted by Numinous professionals like myself, Reid, and others, and include live online classes, experiential learning, and opportunities to connect with a diverse community of practitioners in the psychedelic medicine space. I really love teaching these courses and connecting with you all, so check out numinous.com/training, and I hope to see you at the next training cohort. The content of this podcast does not constitute medical advice or mental health treatment. Please consult with a medical or mental health professional if you believe you are in need of mental health treatment.